ahead. So I will officially open today with a huge big welcome, and it's absolutely wonderful to have you join us. We've had a bit of, 2020 and all that. It hasn't been the best for organising peer groups, so it's really lovely to get started again, because I think the last one we had was in July, so it's been a wee while. Really great to connect. In terms of Bail people here today, it would be really nice if you got to know a few people. So Cecilia, if you want to wave your hand. So Cecilia is the administrator. So you may know Kathy Duncan, you may or may not know. Kathy Duncan, who was our administrator, has bought a business. And she's decided to go off and do framing and printing as a business. So we're obviously sad to see her go, but she's also going to stay involved with us, so you'll probably see her around. So Cecilia's has taken over the administration role, and then Shah Davis, who is now waving at you, has joined us and is going to be more involved in the communication, social media, helping us to get the good news stories about what we do out there, so people know what we're doing. So that's and Julianne, I don't think you have also officially been introduced since you started with Bail either. So Julianne Johns, some of you may know, was working as a speech language therapist here at the DHB in a previous life, and we've grabbed her and brought her on to be involved with many of our research projects as well. So we're really, really excited. But the main thing today is to welcome Catherine Vingerhoets, who is, I will let you, I got the name right. Fantastic. I will let Catherine introduce herself and talk a little bit about her work, but it's really fantastic to have Catherine here, particularly in this COVID-free little bubble, big bubble that we've created for her as a North American. So we're really delighted that you could be here and do the PhD. And Catherine's doing a PhD through my unit at the University of Wellington, so it's extra special to have Catherine here. Later we're going to have Tim speak to us, and I'll let Tim introduce himself when we get there. Tim is speaking to us from the Waikato region, so it's one of the ways we've been able to move forward post-COVID is make sure Tim can speak to us, and hope. And today, I have to also say, today is sponsored by Andrew Hall, who's provided significant amounts of technological support, but he's just so humble. Anyway, I'll let Catherine take over from here.
Thank you, Rochelle. I appreciate it. And Tim, give me a wave if you can't hear me, or if you can't see the screen or anything. Okay, let me know how things are going on your end. So thank you so much, Rochelle, for the introduction. I do appreciate that. So as Rochelle mentioned, I am Catherine, and I'm a PhD student in the Rehabilitation Teaching and Research Unit within the Department of Medicine in Wellington at the University of Otago. And I thought I'll tell you a wee bit about how I arrived here. Let me just see if I can advance the slides first. Maybe I need to use this one.
You might just have to. Let's try. Is it working?
There we go. Perfect. All right. So I am a physiotherapist from Canada. So I have 12 years of clinical experience as a physio in a fairly large regional hospital. That's the hospital that I work at up there. And I live about an hour north of Toronto. So I thought I'd give you a little map just as a reference point to kind of orient you to where I'm from. So I have been to New Zealand before. I worked at the hospital down in Oamaru as a physio in 2010, 2011. And I really enjoyed my time here. I loved being here. So thought it was a good fit to come back for my PhD studies, and I came with my family. This time we arrived just in January, so good timing and enough time to get ourselves settled before COVID arrived and everything changed, but we're plugging along. So before I came to New Zealand, I did a small study back home at the hospital in Canada, and it was looking at the intersection of the elements of evidence-based practice in inpatient stroke rehabilitation. So I'm just gonna, can you see that screen okay, Tim? Okay, perfect. All right, so I thought I'll set the scene just a little bit first before I get into the details of that study, but thinking about what is evidence-based practice. So a lot of us know that it is a model of clinical decision-making in healthcare that integrates information from clinical expertise, research evidence, and patient values, their preferences and expectations to make clinical decisions. So it is a widely adopted and supported model that was introduced by Sackett in the 1990s. It has evolved a bit over time, and this is arguably the most common visual representation that you will find in the literature on evidence-based practice. So if we look at this representation, it is a classic Venn diagram. So each circle represents one of the elements of evidence-based practice, and they all intersect in the middle to create that EVP process. So when I look at this diagram, each of the circles is an equal size. So to me, that says that each element holds equal weight or equal value or equal importance, that each element of EVP contributes equally. But is that true? How does this Venn diagram play out in clinical practice, and how do these elements interact in the real world? So that is what I was exploring with this study. So it was a small qualitative descriptive study using observation and focus group. I used thematic analysis to analyze the data, and the participants were the allied health members of the interdisciplinary team on an inpatient stroke rehabilitation unit. So 3 themes were developed that represent the intersection of the elements of EVP. I'll say EVP from now on if that's okay, because it's just much easier. So the questions that I wanted to ask of these participants of the team, I wanted to know, how do they value each of the elements of evidence-based practice? How does the team utilize EVP in clinical practice? Do they find one element more influential than the others? And what things might contribute to an unequal weighting of the elements of EVP? So the 3 themes that were developed: the patient as the driver, EVP as a fluid process, and EVP as a collaborative team process. And I will unpack those for you today. So that first theme, the patient as the driver, it was clear from these participants that there was a contribution from each element of evidence-based practice in their care planning and their decision-making. But the patient part was by far the most dominant influence. So one participant said, for me, the patient part of EVP is the driver. I don't necessarily think that it's more important, because I think that what the research says and what my past experience says have a lot to say to that. But where they're at is really the driver of how those other things are brought in. It doesn't matter how good the research is or how much I think something is going to help. If the patient doesn't want to do it or isn't going or won't do it, it's not going to work. So I think that quote really kind of nicely sums up that entire theme. This theme was divided into 3 sub-themes as well. So the first sub-theme is the primacy of patient-centeredness. So there was a consensus amongst the clinicians that their processes really focused on the patient as an individual, that the patient's values, their preferences and priorities, their goals and circumstances really guided care planning. They felt that patient-centeredness improved engagement in rehabilitation, and it ultimately affected patient outcomes. So one participant said, the patient part is the biggest, because if the patient isn't interested or isn't buying into what you're doing, you can't get anywhere. The second sub-theme here is patient-directed goals. So goal setting was the most common example of care planning that these participants described during the discussion. And they felt that patient-directed goals were more meaningful for the patients, and that patient-directed goals improved engagement and patient outcomes as well. So one participant said, it's really about what the patient identifies as their concerns and their goals and how to address them. So the third sub-theme here is being patient-specific. It was clear that care planning was specific to each patient and their context. And it was definitely influenced by many factors. So some of the intrinsic factors were patient attitudes, patient beliefs, their preferences, their cognition and communication, but also extrinsic factors like social support, their home environment, and their financial circumstances also played a role. It was also clear that communication, both the strategies that the clinicians used with the patients, but also the information that they delivered, were also individualized to each patient and their situation. So one participant said, "I think it depends on the patient, because sometimes discussing the research can really help with buy-in." So the second theme that was developed is EBP as a fluid process. And by that, I mean it was quite dynamic. So the elements of EBP were valued, prioritized in different ways by different clinicians under different circumstances. The clinicians identified many different factors that influence the clinical application of EBP in their practice. So things like time, staffing, training, access to evidence, organizational priorities, and even physical resources like space and materials influenced how EBP occurred in their practice. So one participant said, "The priorities of the hospital or wherever it is that you're working matter, because what I find is that if I don't have the time to ensure that I'm always doing what the newest, best, or latest research says, I can get into a rut. Then it's my clinical experience taking over rather than the patient's concerns." Another participant said, "Just the availability of materials to make something meaningful. You have to have the right materials to do cooking, or you have to have a kitchen, or spend a lot of time thinking about how you're going to do that in a different setting." The clinicians identified that the contribution from each element of EBP may not always be obvious, that it may act as kind of an underlying influence. So one participant said, "When I'm thinking back to some of the goals we tend to set, a lot of the time they're coming from the research. So you're thinking that way, and that's why you're saying, why don't we have a goal around you stabilizing on your active arm?" So she's indicating there that it's kind of a thought process that's going on in the background, but they may not actually verbalize that to the patient or to other team members. It was clear that EBP as a process evolved over time and with changes in practice. So I'll give you one brief example of a practice change that had occurred quite recently for this team. So on this inpatient rehab unit, team rounds, or rehabilitation rounds we call them, occurs once a week, where the interprofessional team gets together, discusses the patient status, sets goals, talks about discharge planning. And for many, many years, that weekly meeting would occur in a non-clinical space with the entire interprofessional team present, but in a non-clinical space. And then the goals would be discussed with the patient afterwards. This team had recently adopted a change in practice just before I did this study, where they actually changed to bedside rehab rounds. So still the interprofessional team, along with the primary care nurse, would go room to room and conduct their rehab rounds with the patient in the room. So this practice change was something that was new to the team, and it really was highlighted quite a bit throughout the discussion. So clinical expertise also evolves, and we found that novice clinicians really drew on the experience of more senior clinicians. So one participant said, "As someone who hasn't worked in stroke for that long, I'm coming along with my experience. I have more of a reservoir to pull from to say, this person really reminds me of so-and-so." So the third theme that was developed is EBP as a collaborative team process. And it was clear that the process of EBP was influenced by team functioning, and the team was made up of the interprofessional team, so the health professionals who are caring for the patient, but also the health professionals and the patient together as a team. So that's why this theme is subdivided into two sub-themes here. The clinicians did feel that active patient involvement in goal setting really helped them to understand the patient's values, their preferences, and circumstances a lot better. They did acknowledge that challenges can arise when there are differing views or differences of opinions. So one participant said, "Sometimes care planning is a collaboration between what the patient is wanting to work on and the goals that the team identify. I would have loved to have my own goals to see where that patient would be, but it doesn't matter. It's where that patient is at and how to support that patient at that moment in time. The clinicians also talked a lot about reframing patient goals. So they often felt that the patients may not have the knowledge to know how to break down a goal into kind of manageable steps. They felt that patients often set kind of larger long-term goals, and they needed some assistance kind of breaking those down into manageable steps. And so that process of reframing patient goals really relied heavily on research evidence and clinical expertise. So one participant said, this happened in our rehab rounds, the patient saying, my big goals are to walk. They don't know what steps to take or what interventions are going to get them there. They just see that as the end goal. It's about providing education related to our experience. For example, the short-term goal or treatment is what's worked in the past based on how other patients have presented and the research. The benefit of collaboration within the professional team was certainly highlighted throughout this discussion, and the clinicians felt that collaboration helped to broaden their clinical expertise and to ultimately enhance their practice. So one participant said, when you get stuck in that rut, sometimes experience from another professional can say, how about try this? And it opens up a whole other world for you to look at. The clinicians felt that educating others about research and sharing their clinical reasoning really helped the extended team to apply EVP. So one participant said they might learn more about where these goals are coming from and why, what our thought process is, so their interaction may end up being more client-centered in the end. And it was clear that professional collaboration was essential to a team-based EVP approach, and that team approach really enhanced practice of the individual members of that interprofessional team, and then ultimately improved patient-centered care. So the take-home messages from this study are that the intersection of the elements of EVP are a complex and iterative process, and that they are context dependent. That patient values, preferences, and circumstances were the primary driver of the EVP process for this team within this context. That collaboration within the team and between the healthcare professionals and the patient is vital to a successful EVP approach. That the organizational support of all elements of EVP is necessary for the successful application of EVP in stroke rehab. So the findings from this study, particularly the patient as the driver, the greatest influence of EVP, helped me kind of draw a link to another common model of healthcare, which is patient-centered care. So we know that patient-centered care is a well-supported and adopted model. And when we look at the components of these two healthcare models, patient preferences, their values, their circumstances are really one common link between these two models. So there is a lot of literature telling us that we should incorporate and integrate patient values, preferences, circumstances into our care planning and our goals and our decision making. But how do we actually do this? How do we elicit this information from the patients and their families? How do we share this information within our interprofessional teams? What tools or strategies do we use? How do we do this well? And what opportunities might exist to improve our practice? So that is essentially what I am here looking at now. So the first phase of my PhD project will involve short interviews with clinicians to talk about their experiences eliciting patient values, preferences, and circumstances in the context of inpatient neurological rehabilitation here in New Zealand. I think if we can do a really good job at this, it really puts us in a better position to truly understand and integrate that information into our practice. So again, this is just the first phase of the project, the first qualitative phase of the larger PhD project that will explore the topic. So the goal at the end of this is a potential development of a toolkit or some tangible, clinically relevant takeaways that we can use to hopefully improve our practice. So that is kind of the overall plan of the project at this point and kind of where it came from in the first place. Does anybody have any questions for me about the study?
Can I ask, is there
gap between what therapists think they provide in terms of person-centered care and with what people perceive they have received in terms of person-centered care.
Yes, so the literature does show that the clinician's perception of the patient-centered care that they provide might be different from the patient's perception of that care as well. Yeah, absolutely.
I'm just wondering, are you going to in any way collect data about patients' perspectives of how person-centered preferences could be included in rehab planning and team processes?
Yes, that is certainly a goal for one of the latter phases of the project. Again, this is just kind of initial phase, phase one qualitative work to kind of lay the groundwork, because there really is very little literature on how we actually elicit this information. So I'm starting with that, and then that will certainly develop through the latter phases.
Obviously, there's a lot written about the evidence-based practice and criteria of what falls within that and outside that. I mean, at the end of the day, you'd be able to do that when you can come up with a very clear criteria as to what is actually evidence-based practice.
It's actually not one of the objectives of the PhD. So creating this link and kind of identifying the patient values and preferences element of EBP has kind of evolved my project plan into specifically looking at that element, and particularly how it is influenced as part of patient-centered care. So it has evolved a wee bit from that EBP study into a more patient-centered care approach, because it's interesting when you look at EBP, that one element of EBP seems to be the least defined element. It's fine to say that we should integrate patient values and preferences, but what does that even mean to us? What do those terms mean to us as clinicians? What do those terms mean to patients, and how do we define those terms? So that's part of what I am exploring. So it's more about the specific element of patient preferences, values, and circumstances, and then how can we elicit that information in a way to improve our patient-centered practice.
Following on from what Rochelle was getting at, it occurs to me that doing the clinician aspect at the same time as the patient one, and in fact even delving into specific directions. So did you know, for a particular patient, getting the perspectives rather than sort of doing a population of clinicians, and then okay, we've done that, but now on the next stage, then we've got a population of people in the exact same situation. The patient's perspective on it, as opposed to the clinician, a particular interaction could be kind of revealing.
Oh, ethnography, here
yes,
we come.
That's right. And hopefully one of the latter phases will be more observational. So actually observing interactions and looking at all of the perspectives at the same time. Yeah, absolutely. Any other questions? All right, fantastic.
I've got one question.
Sure.
So the big issue from a health service, I'm sure you guys find it as well, when you're trying to provide services to people with a limited budget and there's constraints on what can be offered and their preferences go beyond what you can actually offer within your service or within the funding. Are you going to explore that tension at all within rehab teams?
I'm sure that it will come up, but that's why I think this process is context dependent.
Yeah.
And I think that kind of theme really flows through that previous study, and I anticipate that it will come up in throughout this whole project, because you're right, there are so many factors that influence how we're able to enact patient values and preferences based on resources, but there are ways around that too. So
yeah,
how do we do that?
Yeah,
It's a good question.
Marty.
What the comment coming for what really good here. What how you research like getting perspective from the clinicians, it's also really important to keep a person because they're just giving their perspectives. But from the patient, a kind of a glue also.
Absolutely. Very important. Yep. Yep. Certainly all ties together. Absolutely.
Just an observation that one of the things we come across a lot is patients or residents, their perception of the upper limb recovery, whereas clinicians would, there's definitely a conflict there. They'll often say, well, I'll never got better because I never got a proper crack at it, whereas the clinician might say, well, it's not going to get better, so you can give it a proper crack. So that is one thing that comes up.
Yeah, that's a great point.
It's a really good point. And actually, your comment about I think clinicians often use evidence-based practice as a bit of a weapon to say I'm in a more powerful position and I'm going to decide what you do or don't get, and it kind of shut down people who want to explore options and preferences. It's a real challenge.
Hi.
I just got a practical question.
Sure.
How are you going to get the opinions of people that perhaps are unable to voice their own opinion at the time due to their
We haven't developed the participant or the patient phase yet. So at this stage, I'm just starting the first phase, which is the clinician interviews. And so there will still be a lot of planning and development. It will involve caregivers and families and communication partners as well to include communication from everybody, because you're right, it is a very common impairment amongst patients with neurological injuries, stroke. So yeah, absolutely. Thank you.
Jen's asking that one because she's having to develop it at the moment for another study. So she was hoping to get ideas from you.
And we can chat after.
And Julianne, who's sitting behind, is speech now, and she might be able to help.
Wonderful. Thank you.